Thank you very much. Good morning, everybody. So what I've been asked to do is talk about how I would perform a virtual cross match, and this is in Leeds. And before I tell you about that, I thought I would do a quick Google search of what a virtual cross match is, and I came up with three common themes. One is an assessment of immunologic compatibility between a recipient and donor, and that's based on the assessment of their HLA type as well as the recipient's antibody profile. A virtual cross-match is a cross-match that does not require any bench work or laboratory work at the time of transplant, or a virtual cross-match assesses the donor and recipient compatibility but without the use of donor cells. And as Prof. Torpy alluded to earlier on, why do we perform a virtual cross-match? And the main reason is to minimize the laboratory contribution to organ cold ischemic time and to facilitate the surgical flow. We use the virtual cross-match in order to predict the likelihood of a positive wet cross-match, but also to risk stratify the transplant should it proceed. And I'm going to focus again on the virtual cross-matches that we perform in a deceased donor setting, although we do also use it at the start of transplant workup for live donor pairs to guide recommendations for whether they go for direct or via the kidney sharing scheme. So what do you need for a confident virtual cross-match? You need the donor HLA type, and then the recipient HLA type, and we type our donor and recipients to ABC, DRB1, DQ beta1, DQ alpha1, DP beta1, DP alpha1, and DR345. We also need to have a recipient's HLA antibody profile, but really we need more than one test. And what we would like to do is look at the patient's HLA profile over a long period of time. And often in some of our cases, we'll have a longitudinal historic profile that will span a decade. The patient sensitization history is also incredibly important, and that helps us understand the antibody profiles that we have in front of us, but it also allows us to choose which serum sample we would like to use in order to inform the virtual cross-match. And I've mentioned transfusions, pregnancy, and transplants, but also I'd like to know if a patient has had a vaccine recently or a serious infection, as that could affect the choice of serum as well. And I thought I would briefly give you an overview of our antibody screening program. So we are an FE, a European Federation for Immunogenetics accredited laboratory, and part of the requirements is that we screen all of our recipients every 3 months. In order to save costs, rather than doing a single antigen bead test every 3 months, we will do a lab screen mixed class 1 and class 2. So this is the pool bead assay. And if we find a positive result, we will then do a reflex test to a single antigen bead. And we will do that at minimum once a year. For our more sensitized patients who may be undergoing delisting programs, we may do that more frequently, and it'll usually be sort of around 3 months. We do receive a lot of samples from our recipients, and we will always store them. And we also encourage our transplant coordinators to send us additional samples if a patient's had a sensitizing event. So 2 weeks after a blood transfusion, we'll ask for another serum sample. So in Leeds, what is a virtual cross-match? And what I've tried to do is group them into 3 separate areas, sort of according to a traffic light scheme. So we have what I call a true virtual cross-match, which is where we do not perform any laboratory work when we receive an offer. And this can be for patients who are unsensitized, where we have not found an HLA antibody. We can also do this true virtual cross-match for patients where we know they have antibodies, but a lot more input from the consultant is required during the time of offer. And then finally, in the red traffic light, we perform time of offer work. This is usually a single antigen bead test at the time of offer, and this allows us to inform the progression of a virtual cross-match. And what I'll do is go into each of these in more detail. But taking all of these into account, for our deceased donor population, we perform approximately 80 to 85% virtual cross-match rate. And I would say about 50% of that is based on time of offer work. So a true virtual cross-match, these are for selected patients only. And what we will do is we will create a virtual cross-match list that gets released once a month. And if a patient appears on that virtual cross-match list during that month and they receive an offer, a compatible report is issued straight away without any need for any further input from the consultant. So because of this, they have to be highly selected and have strict eligibility criteria. For those who have had no documented sensitizing events, we need to have tested them consistently negative for HLA antibodies. We've needed to at least screen them at least twice in the last year, and the most recent screening test must be within 3 months. So if that happens, you can potentially let a patient go to transplant based on a negative screen within 3 months. If they have had a previous transfusion, transplant, or pregnancy, we're a bit more stringent. So again, they must be consistently HLA antibody negative, but the important thing is that we needed to have performed a single antigen bead after the event, and that has had to be negative. As I said, we're a bit more stringent, so we will probably allow 30 days for a 30-day-old sample to be used for a virtual cross-match. We also perform delisting policies in our center, and if a patient has had a previous transplant and the current offer represents a repeat mismatch, we wouldn't allow them to go ahead on a virtual cross-match. We would want to do some time of offer testing. Moving on to sensitized patients. This is very much consultant discretion, so a consultant will have to review the patient profile before issuing the cross-match. This is usually for patients who have a stable HLA antibody profile or one that we've seen contracting over time. And usually by chance, they've already sent us a sample, we've tested it, the results are there and available within the lab. And taking a straw poll amongst my colleagues within the lab, we would usually be happy to permit a virtual cross-match if we have this stable profile, provided that it's no more than 30 days old, and provided that there's no subsequent sensitizing events. So this is something that we'll always have to communicate with our coordinators. We need to be happy that there's no antibody conflict with the donor, and we have to have confidence in the donor type and the antibody profile. And finally, if all of these patients and offers fall out of those set criteria, we will do time of offer work, and that's usually, as I said, in the form of a single antigen bead test. And we have a rapid protocol which allows us to turn the results around between 2 to 2.5 hours. So what I thought I'd do is try and explain all of this in form of an example. So I've got a 60-year-old patient who's on home hemodialysis. He's a highly sensitized patient and has had 2 previous failed transplants, and he's also had blood transfusions. His CRF currently is 99%, so he's incompatible with 99% of the last 10,000 donor pool, and he's waited just under 6,000 days for an offer. Because of his wait time, he receives a priority offer on our tier A, which is the priority tier, and it's a 001 mismatch. And so that's a virtual cross-match that has been performed by NHSBT based on the information that we've provided with them. We pull his file, and we can see that there's no repeat mismatches from his previous transplants, although we don't know the C, the DQ, or the DP type of donor 1, and we do not know the DP type of donor 2. Because he's a highly sensitized patient, he's been undergoing active delisting strategies, and one of the things that we did was we removed antibodies that we hadn't seen for 2 years. So this is the information that we have. We've got the recipient type on the left, and because he's highly sensitized, we've performed NGS sequencing. And the information that we have from the donor center is the donor type on the right, and this was performed by PCR SSP. As I've said, this is a 001 mismatch, and I've highlighted the mismatches here. So there's a DR17, DQ2, DR52, DPB10201, and also the donor is DQ alpha 105, but we have no further information on the allele. I've now included his cumulative antibody profile, and this is over 12 years of data. And I've also highlighted the antibodies that we've removed from his profile because we haven't seen them in excess of 2 years. And then what I've now done on the donor type is highlighted some more areas of interest. The DR17 is more interesting now because he has in the past developed antibodies against DR17. We've not seen that for over 2 years. And we can see in his cumulative antibody profile that he has DQ alpha 0503 and 0505 antibodies. So there could potentially be a donor-specific antibody here. So I went and I reviewed his single antigen bead results, and actually over the last 2 years, we've had invalid class 2 results because he's had a high negative control reading. But prior to 2 years, we had a valid result with a C702 donor-specific antibody, possible donor-specific antibody with 4,000 MFI. We don't know whether this is donor-specific or not. The recipient is CO701, and the donor has CO701 and O2 in the string. We also can see that he has in the past developed these DQ alpha antibodies, approximately 3,000 MFI. So to summarize the information we have at the moment, before we do any extra testing, we've got a 001 mismatch. We've got an increased risk transplant because there are historic antibodies and there's a risk of accelerated rejection, but we're also unable to rule out 2 potential donor-specific antibodies that could increase the risk further. But we've got a sample that's in the lab from 7 days ago. We did a screen test on it, which was positive, so we've pulled it out and we've decided to do a single antigen bead assay. And we've gotten in contact with the coordinators and asked them to confirm that the patient has not had any further sensitizing events, no blood transfusions, vaccines, no infections. We've also, at the same time, requested some peripheral blood from the donor in order for us to perform some local retyping. And this is the information that we received. So we have a LinkSeq RT-PCR. We use a slightly higher resolution kit. It's the SAB-R kit, and it provides the same resolution as a single antigen bead, which is why it's called SAB-R, SAB resolution. And with this, we were able to exclude both the CO702 and also the DQ alpha 0503 and 0505 as donor-specific antibodies. At the same time, we performed single antigen bead testing. We had to perform it twice because of high negative controls. And what I've done is I've highlighted the donor-specific antibodies, which were of no concern. So this is class 1, and you can see that the recipient alleles are all negative, and class 2 similarly. So we were able to issue a virtual compatible virtual cross-match report prior to the arrival of the kidney with recommendation for post-transplant monitoring. But what this case has highlighted are some pitfalls. We often receive antibody profiles that are at higher resolution than the available donor type, which is why we've introduced the SAB-R kit in Leeds. There are gaps in the antibody kit, as has already been alluded to. So how do you manage this? Do you look at surrogate beads? Do you look at an alternative vendor? The tests that we perform only look at HLA antibodies, but there are some other non-HLA antibodies that could be problematic in transplantation. And as with all antibody beads, single antigen beads, we have problems with false positive profiles that we need to be able to get around. I've listed the common alleles that are not represented in our panel, and I fully appreciate that this might be completely different to you in terms of your donor population. One of the things that we do routinely, for example, with DPB104, is that we know that's structurally almost identical to DP3, so we'll use that as a surrogate bead. And we are thinking about adding in Verfin and Xplex testing just for to try and fill the gaps in limited cases. And if the virtual cross-match is inconclusive or positive, we will go to a wet cross-match, and I've just included our cross-match policy here. So to summarize, the virtual cross-match can be used in lieu of a wet cross-match in selected cases only, but requires a good, adequate donor typing, very good knowledge of your donor sensitization history with a long historical profile, and also good understanding of your antibody panel and the typing kits that you have available to you. As I've said before, it doesn't look at non-HLA antibodies, which is something that needs to be considered as well. But thank you very much for your attention.